Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on diagnosis of ruptured pulmonary hydatid cyst by flexible fiber optic bronchoscopy. You can access this lecture by visiting my YouTube channel named Professor Abdussalam Yassin Taha, by visiting this website. History of fiber optic bronchoscopy and pulmonary hydatid cyst. Dr. Azhar Kamil Kassab, a cardiothoracic and vascular surgeon, is credited for introducing fiber optic bronchoscopy in Iraq in 1976. I was lucky to work several months with Dr. Kassab in 1990 and learned the procedure, and in 1995 I have established a unit of fiber optic bronchoscopy in Basra, which was the only unit in southern Iraq. By 2003, around 850 fiber optic bronchoscopies were performed. Many doctors were trained, and 2 original research works were published by the author. For the first time, the use of fiber optic bronchoscopy for definite diagnosis of ruptured pulmonary hydatid cyst was reported by the author in a conference presentation at Baghdad in 1998. In October 2003, I moved from Basra, south of Iraq, to Sulaimani in the region of Kurdistan, following an invitation from the Minister of Health in Kurdistan, and began to establish a unit of cardiothoracic and vascular surgery, which was the first in Kurdistan region, Iraq. That was the bronchoscopy unit that we have established for both flexible and rigid bronchoscopies in Sulaimaniya Teaching Hospital at 2003. And that was the staff of bronchoscopy unit in Sulaimaniya Teaching Hospital 2003, consisting of me and some assistant doctors and paramedical personnel. I have published a paper entitled "The History of Introducing the Fiber Optic Bronchoscopy in Iraq" in the Journal of the Egyptian Society of Cardiothoracic Surgery at 2017. In this paper, I have summarized the story of introducing fiber optic bronchoscopy in Iraq from the very beginning. By 2010, about 790 fiber optic bronchoscopies were performed, and dozens of doctors were trained by the author in Sulaimaniya, beside publishing more research papers about fiber optic bronchoscopy. The main indications for fiber optic bronchoscopy in our practice used to be diagnostic for patients with a wide range of malignant and benign conditions. The commonest was bronchogenic carcinoma. On the other hand, a minority of patients underwent fiber optic bronchoscopy for therapeutic purposes, such as removal of aspirated foreign bodies. In 2005, the author published a paper on diagnosis of pulmonary hydatid cyst by fiberoptic bronchoscopy, and this paper was published in the Journal of Thoracic and Cardiovascular Surgery in 2005. This journal is a prestigious journal, and this paper was considered an original work and the first article on fiberoptic bronchoscopy and pulmonary hydatid cysts. A full text of this paper is available by visiting this website. To summarize the paper published in 2005, we can say there are three radiological signs considered diagnostic of ruptured pulmonary hydatid cyst. Number one, the perivesicular pneumocyst. Number two, the double domed arc. And number three, the water lily appearance. Apart from these, every localized radiological density seen in any patient above the age of 3 in an endemic area should be looked upon as possible ruptured pulmonary hydatid cyst. Nevertheless, situations where the diagnosis of ruptured pulmonary hydatid cyst is difficult are far from being rare in countries of high endemiology. Thus, a preliminary bronchoscopy is a perfectly justifiable step in the diagnostic workup. Herein, I report 6 selected cases of ruptured pulmonary hydatid cyst in whom definitive diagnoses were made using the flexible fiberoptic bronchoscope. A review of the computerized medical literature from 1966 to 1998 revealed no single article on fiberoptic bronchoscopy and pulmonary hydatid cyst. That is the appearance of the laminated membrane of hydatid cyst, whether in the lung or in other locations. It is a white, thick, proteinous membrane, which is pathognomonic of the cyst. The first case was a 36-year-old man who had presented with 1-week history of cough, greenish sputum, fever, right-sided pleuritic chest pain, and hemoptysis, with a normal physical examination. The plain X-ray of the chest, PA view, revealed a rounded opacity in the superior segment of the right lower lobe, which was confirmed by the lateral review to be located in the superior segment of the right lower lobe. Fiberoptic bronchoscopy revealed a whitish material, that is a laminated membrane of ruptured pulmonary hydatid cyst in a subsegmental orifice of the apical lower segmental bronchus. And that is the appearance of the ruptured pulmonary hydatid cyst at bronchoscopy. The whitish laminated membrane is visible in the bronchus. The second case was a 36-year-old man who had presented with a 3-month history of intermittent fever and dry cough. Chest examination showed or revealed right-sided wheeze, and the plain X-ray of the chest PA view revealed a persistent homogeneous diamond-shaped opacity in the right upper zone, bounded inferiorly by the interlobar fissure. The initial impression was either a ruptured pulmonary hydatid cyst or encysted pleural effusion. Fiberoptic bronchoscopy revealed a laminated membrane in the anterior and posterior segmental bronchi of the right upper lobe, and right thoracotomy confirmed the diagnosis. That was the big laminated membrane of the ruptured cyst. The third case was a 26-year-old lady who had presented with a 2-week history of cough and massive hemoptysis. The plain X-ray of the chest revealed an ovoid opacity in the left upper lobe, and the lateral view showed the opacity in the left upper lobe. Fiberoptic bronchoscopy revealed fresh bleeding and a laminated membrane in the lingular bronchus. Left thoracotomy revealed an infected, disintegrated membrane, and that membrane was removed via thoracotomy, and the patient had a smooth post-operative course, and as you can see, the post-operative chest film showed a fully expanded left lung. The fourth case was a 23-year-old man who had presented with a 3 years history of cough and hemoptysis, and the plain X-ray of the chest showed an ill-defined opacity in the left upper lobe. The lateral view located the opacity to the apico-posterior segment. The patient had a past history of laparotomy 3 years earlier for liver hydatid cyst, and the old X-ray of the chest showed a water lily sign. The water lily sign is pathognomonic of ruptured pulmonary hydatid cyst. So the differential diagnosis was either ruptured pulmonary hydatid cyst or pulmonary tuberculosis. Fiberoptic bronchoscopy revealed a visible laminated membrane in a segmental bronchus of the left upper lobe proper. Left thoracotomy showed a suppurated ruptured pulmonary hydatid cyst and destroyed lobe. Therefore, left upper lobectomy was performed, and the patient had a smooth postoperative course with fully expanded left lung as revealed by this postoperative chest film. The fifth case was a 28-year-old man who had presented with 1-year history of cough and hemoptysis, and the plain X-ray of the chest showed a rounded opacity in the left lower lobe, and the lateral view showed the location of the opacity in the posterior basal segment of the left lower lobe. Fiberoptic bronchoscopy revealed a bleeding and laminated membrane in the left lower lobe bronchus, and left thoracotomy was performed for removal of suppurated ruptured pulmonary hydatid cyst. The sixth case was a 30-year-old man with 2 months history of hemoptysis and expectoration of small intact hydatid cyst. The plain X-ray of the chest showed an apical opacity and an elevated right hemidiaphragm. The lateral chest X-ray showed an apical segmental opacity, and the abdominal ultrasonography revealed multiple liver hydatid cysts, while fiberoptic bronchoscopy revealed a laminated membrane in the apical segmental bronchus of the right upper lobe. So that movie showed the actual appearance of the laminated membrane of ruptured pulmonary hydatid cyst during fiberoptic bronchoscopy. If the patient is fortunate, then this finding is diagnostic of the disease and reveals other differential and excludes other differential diagnosis. The use of the bronchoscope in the diagnosis of doubtful cases of ruptured pulmonary hydatid cyst is not new. Professor Farouk Saidi reported a case of 6-year-old girl with left lower lobe ruptured hydatid cyst diagnosed bronchoscopically by visualizing an intrabronchial laminated membrane. In his opinion, such a finding can be observed by surgeons with extensive experience in pulmonary hydatid cyst. 2 other cases were reported in Tunisian children aged 5 and 10 years with chronic pulmonary opacities posing a diagnostic problem. Worthy of mention that both workers used the rigid bronchoscope. A bronchoscopy is actually unnecessary in cases of ruptured pulmonary hydatid cyst with a pathognomonic clinical picture, radiological picture, or both. However, it is indispensable when there is suspicion of tumor or when the radiological picture is atypical. In this study, all the reported cases had atypical radiological signs. Fiberoptic bronchoscopy enabled a definite diagnosis in all of them. In a place endemic in pulmonary tuberculosis like Iraq, The combination of hemoptysis and persistent pulmonary opacities is quite suspicious. Fiberoptic bronchoscopy rules out this diagnosis by visualizing the membrane of pulmonary hydatid cyst. This is another example of the advantage and superiority of fiberoptic bronchoscopy due to its characteristics, safety, small size, flexibility, and better vision. It's worthy of mention that all our cases had the laminated membrane in either segmental or subsegmental bronchus, which otherwise could be missed by the rigid bronchoscope. So along with other workers, Henry P. et al. And Farouk Saidi, this article strongly shows the advantage of bronchoscopy and fiberoptic bronchoscopy in particular in the diagnosis of puzzling cases of ruptured pulmonary hydatid cyst. And this is the end of our lecture. Thank you for watching, and I hope you enjoyed the lecture.